there are a lot of impacts of sequence. Certainly, I think we are expanding the necessary infrastructure to do it well. And doing it well means that you have to actually have data, and you also have to have ideas, and you have to have leadership that actually has followers in order to get anything done. I think sequence actually facilitated a lot of that. We developed and created delivery of educational opportunities for staff in addition to physicians. I think that having sequences was a recruitment tool and a retention tool for physician staff. I think the whole idea is around making things better for patients in a sustainable, systematic way. I think that my career has really been mostly about doing that, but I think the idea of spreading my ideas beyond required something like a center in order to have that influence.
Welcome to Pemba On Demand. I'm Norm Chapin, your host. I am very excited to welcome you to our podcast. Pemba On Demand is produced for physicians interested in professional development. We will be discussing a wide range of topics on the podcast. I will be interviewing physician leaders from the U.S. and from other countries who have graduated from the Physician Executive MBA program at the University of Tennessee. These physicians will be sharing stories of professional and personal growth, overcoming challenges in their organizations, and discussing key leadership skills they have learned from the MBA program and ongoing professional development. In this episode of Pemba On Demand, we are releasing the live stream from our October 15th, 2024 live stream. Our guest is Dr. James Calvin. Dr. Calvin and I will be discussing the creation of a Center for Quality, Safety, and Innovation in an academic department. Dr. Calvin is a cardiologist, researcher, and physician executive. Good afternoon, everyone, and welcome to today's Pemba On Demand live stream. I am Norm Chapin, your host for the live stream. The University of Tennessee Haslam College of Business is the sponsor of the Pemba On Demand live stream and podcast series. The live stream today is allowing alumni to join using an integrated Zoom link. We will have you muted during the live stream, but if you would like to ask a question or make a comment, please feel free to do so in the chat. If you have a question, please type a capital Q followed by the colon sign and then your question. It will be a little bit easier for the guest and I to identify who has questions that we would like to answer during the live stream. Pemba On Demand has been developed to provide education for physician leaders and to bring the latest and most relevant topics to you. Each live stream focuses upon an aspect of physician leadership, innovation, career development, or the business of medicine. We're glad that you're taking advantage of these practical, insightful, and relevant discussions designed to help physician leaders get new and build upon existing leadership skills and perspectives. Pemba On Demand will allow you to be an even bigger force for good in healthcare. CME is available for this live stream. Simply visit tiny.utk.edu/Pemba On Demand, all one word, to obtain your CME certificate. Our live stream today is regarding the development of a Center for Quality, Safety, and Innovation in an academic setting. I'm pleased to have our guest today, Dr. James Calvin. James is a fellow Pemba alumnus, graduating in 2011 from the UT Pemba program. Dr. Calvin is a cardiologist, researcher, and physician executive. Jim, welcome to the Pemba On Demand live stream.
Thank you. Appreciate being here. I hope you hear me okay.
Yes, thank you. I'm really pleased to have you on the show today. Thanks for taking the time out of your schedule to join us. So I thought we would get kind of right into our main topic today, which is the development of a Center for Quality, Safety, and Innovation. I wonder if you could start by telling us a little bit about why you initiated this project while you were at Western University, and what problem were you facing that you were trying to find a solution for?
Well, certainly I should give a little bit of background in that I had actually worked at both Cook County and Rush University Medical Center for a total of 21 years before I took the job in Western. And that certainly did give me an opportunity to do a lot of quality improvement, especially during the time that I was director of the coronary care unit. So I became quite accustomed to payment for performance, CMS data sets that were required to actually show that, in fact, patients are receiving good care. And then I went to Canada expecting it would be the same, and it was not. Quality was largely a department within a hospital. There was really not much of an academic connection to it at all. On the other hand, I had young faculty that wanted to be able to improve the system and actually had gone off and gotten master's degrees in quality improvement. And so they needed a home. And we needed to actually build a workforce that was that had the skill sets for quality improvement. So and it so happened that I was doing recruiting for people who actually had backgrounds in quality improvement in my first term. And on my second term, we got involved with negotiations about renewing. And one of the things that the dean and I settled on was this quality improvement effort in building a center. And this did involve some organization and administration and politics, because I not only had to get his permission, I also had to get funding from the affiliated hospitals in London, as well as Western University, which are all separate corporate entities. And so we put together an application to get approval for a center, and we got ourselves started.
Great.
And
well, let me we'll have you go right into your presentation here. Thank you for that background. Just let me know when you'd like to switch to the next slide, and I'll kind of navigate us through that.
Okay, thank you. So the title shows that this is a 3-year review because I was stepping down as the chair of the department. Instead of having a 5-year review, which is customary for Western University, we put together a 3-year review to see what kind of shape we were in. So much of what I'm going to talk about is actually a 3-year experience. And so you can judge for yourselves in terms of the progress that we made. I will tell you that in addition to an internal review by Western faculty in the medical school, we also had an external review by the Royal College of Physicians and Surgeons of Canada, who actually oversee training programs. And they gave a strong recommendation that it should continue even after 2 years. So the next slide, get it started. So what do I want to cover today? I show you some of the accomplishments that we had, give you an outline, very brief outline of strategic planning that we did do before I left. And we were, at the time that this was written, we were asking for additional resources to expand the educational research programs, take the mandate beyond the Department of Medicine into other departments, support clinician development, and that includes not only hiring people with training in QI, but also improving their game, if you will, even after they've established themselves as a faculty member. We had to attain Royal College educational goals because they've been incorporating that into the expectations for training programs. And we had to ensure institutional quality objectives were being achieved. In other words, if we wanted to have continuance from the hospitals, we had to do projects that were consistent with the hospital's missions. Next slide. So I gave you a little bit about the background of the negotiations, but clearly QI is becoming a national and a provincial and local priority. Increasing public awareness of the Royal College requirements, and medicine continues to progress. And so the implementation of new technology or new treatments has to be thought out as to how to be the most effective and efficient with that. And all the time we're trying to do this with a very fiscally challenged environment. Let me just say, from the time that I became the chair of the department, the largest teaching hospital was already suffering $20 million deficits, which continue to increase over time. So, a very strained system, but one that really needed to have this investment. And obviously, if you want to have excellence in your department, you have to actually develop leaders, have the expertise on the clinical medicine side, but also on the infrastructure that's crucial. And what I really hoped for is that this would allow us to take a more active role in developing the landscape so that we had a greater hand as physicians to improve patient outcomes and survival and promote the academic development of our faculty. Indeed, when I first came to Western, there really wasn't anything built into the documents around promotion that had said anything about quality efforts or quality improvement time. And that was one of the main reasons I think that the faculty who are interested in this supported our efforts, because they needed to have more of an impact at the university level as well as at the hospital level. Next slide. So I told you a little bit about this at the beginning of how it came to be. We were trying to show that in fact such an entity was actually feasible. And so the Department of Medicine was acting as a pilot, and the hope was that it would actually spread to other departments. And certainly I think that I was trying to answer the needs of the faculty who had advanced training in QI and wanted to see their career progress along those lines. We set it up in such a way that for members from other departments could also participate in some of our activities. And what we found was that there was a great deal of interest from individuals in other departments. And in fact, later on, I'll actually show you some projects that were done by individuals other than the Department of Medicine. So I think that we were meeting our goal then of being able to spread.
Has the subsequent to, as it went on into year 2 and year 3, did you see that this model was adapted by other departments, or did you find more members of those departments participating with your Center for Quality and Innovation?
Well, we have presented this to the chairs of departments, and they were hiring people who had the interest and the training, but needed a home. If you have one person out of 30, you don't really carry a lot of weight. On the other hand, if you actually are part of a group of people that might be 30 to 50, suddenly you've got a place where you can go to, ask questions, explain thinking around projects and how those projects might develop, and know that you're in an audience of people that you can trust who actually speak the language that you've learned. And so I think that we found early on that people were attracted to it. And we've presented it in a number of places so that people were aware of it and sought out, sometimes through our junior faculty, people from working in the hospitals and have heard about it and what's going on and ask, well, can we join? And so we made it easy. Next slide. So this slide, I'm not sure how well you can see it, but essentially there were really 3 pillars. We were trying to improve patient outcome, reduce adverse events, and innovate in healthcare. Our goal was really to attain a goal of setting standard for excellence in healthcare quality. And so we approached it in that manner, although I would say we didn't build a house at the very beginning. We were kind of working with lean-tos and tents in the beginning and trying to get people moving and facilitate projects as best we could in the beginning to build up momentum and to encourage people that they could pursue this as a career.
So you had something to keep the rain and the snow off people, but no central heating or central air conditioning at the beginning.
No. And a lot of this was funded by the department. There was a sizable contribution from hospital and from the university, but in fact, by the end of the 3 years, our infrastructure was probably about $1 million in costs. So it's a significant effort because you need program coordination, you need data collectors, you need people to actually help facilitate projects and be project officers over and above the faculty salaries themselves. So it took a while to kind of build up that support.
So one of the questions that we just got in, Dr. Leiter's on, and had a question about if there was a specific approach you used to get the resources you needed for the QI program, especially because this is an academic center. How did you approach that as you needed to provide more resources to take on more projects?
Well, that's the rub. Well, first, Don, I got myself a tin can so I could go out there and ship with the university and with the hospitals, and served on their leadership committees, got to know senior leadership in all of the organizations. And as you'll see later on, we even created essentially a governing board that included the major sponsors so that I could actually show them results. The initial commitment was really kind of a retention commitment to me to stay and do a second term. And so while I didn't use it for my own salary, it did allow me to hire and support faculty as well as program director, which were kind of critical in the early days. We have gotten grants from organizations within Southwestern Ontario. There is a physicians organization that creates granting competitions, 2 competitions yearly that people applied for and got operating funds for their various projects. I think that by the time I was leaving, there was a need to kind of figure out what we were going to have to do in the future, which I kind of saw as a need to gather more support from philanthropy in the form of the hospital foundations as well as other organizations, more activity on research grants. And one of the things that one tries to do when you're starting something up and you're really creating seed funding, you really want people to do projects that produce data that can actually be used in support of grants. So that, I think, was critical, and we did have some successful candidates that got grant funding that allowed actually little sub-programs to develop. It's a constant issue, though, is how do you keep the money flowing? And especially when the hospitals are not doing very well. And so that you would really that the hospital should be supporting this. The hospitals do what the government tells them to do. They don't necessarily, the government doesn't tell them you need to have a mandate for quality. They just tell them, we want to see what your fall rate is. We want to see what your hospital infection rate is. And the rest of it, of how you actually build a team, they weren't so interested in. So you really have to find some people that are passionate about this and see this as a need that's going to continue.
Thank you.
Next slide. So next slide. So this is our structure. I thought at the beginning that I would have a research committee and an education committee. Then I did interviews with all the people that were interested in joining. And I found that a lot of those people didn't really have a clear distinction in their mind of whether they're going to teach it or whether they were going to do it or whether they were going to actually study it. And so led us to kind of change our approach. We still had a governing board as I spoke to, which made our sponsors actually intimately involved in what was happening. We had an advisory committee of senior members of Sequins. I served as the executive director, but I did have help. I had a program clinical lead and educational program lead. The educational lead was really important because the educational program started off quickly. And we spread our programs not only into the residency program, but also into hospital staff, as well as the Ivy Business School. Can you imagine that we were teaching quality improvement to business students because they really didn't have any healthcare experience in quality improvement in that genre? So we also created a faculty members committee, and we hired secretarial support, curriculum development support, and we also had one QI consultant who was a non-physician, but had done the University of Toronto QI Masters and was interested in healthcare. And so this was kind of the skeleton team, which I think was effective. It was small enough that everybody knew everybody. And they all had assignments that made sense to them as well as to me. So that's how we started. One would imagine that over time, as it would spread to other departments, that there would be parallel structures in place. You go to the next slide. That's me. These are just some of the people that supported me in this venture. I've alluded to them, but when I first came here, first came to Western, obviously, these people did not have these kinds of roles because there was really no director for quality of the department. Louise was a site chief for nephrology. Alan had only been in practice a couple of years, but he had done the master's program. Joan was an educator that worked at Western, and Joe Carson was the QI consultant who had also done the master's program. It's kind of important to realize that you couldn't jump out and create your own master's program until you actually had faculty with the expertise. So you had to start small, support the people that had good training elsewhere to become the core of what might happen in the future. Next slide. So if you're a part of the Department of Medicine, you could become a full faculty member. And we created associate memberships for pretty much everyone else, people from other departments, as well as hospital administration, which includes the quality department from the hospital, and people who might be member of a quality improvement team somewhere in the hospital. Executive leadership, obviously, we brought them in on the governance board as well, but we actually reached out to various vice presidents to really participate in some of our activities going forward. Next slide. So strategic goals, I can hardly read it, so I'm sure you can't, but we had them. They were pretty simple. They were more goals than specifics, because at the beginning, you're kind of making it up as you go along. I think that if I talk about leadership, I think having courage to be able to just do something and see what happens, risking failure, is kind of important in all of these things because you don't know. It's not as if there was a map. The best we could do is probably copy University of Toronto, which had a master's program, but they had about a decade or more on us. We had to figure out what we could put together in the short term and do it really within, as it turns out, we had to do a 3-year review, not a 5-year review, because I was leaving, I was retiring. And so that meant you had to move pretty quick to have something to show at the end of 3 years. So next slide. There are a lot of people that are craving this sort of thing. Once you start to actually map it out, you can see that everything from primary care to administrative clinical redesign teams, other departments, the public at large, postgraduate medical education wanted us to take on the task of teaching all residents from all programs. And so there were some organizations already under the Western mantle, like the Center for Education, Research, and Innovation, which we actually tied into. And we tried to use resources from the hospital, human resources available on the quality side from their quality department. So you can see that relationship building was a big part, and word of mouth was also a big part. And putting together, presentations. I did a set of presentations to department chairs to actually entice them to support faculty members to join with a full membership. And so we had to put together a package of things for people to actually see what it was about. And so it actually kept us quite busy. Next slide. This just gives you an idea, really, of the expansion beyond the Department of Medicine that was possible. So you have various departments or administrative groups, as well as divisions within the Department of Medicine. The divisions are in blue, everybody else is in orange. But you can see that even within, at the 3-year mark, we had a pretty significant buy-in from people throughout the organization. This did not exist when I started. It did not exist in the first 2 years. There was a lot of preparation before year 5 to be able to take this step. And the leverage I used was that I might leave. So that's important. You do have to understand what is important to the people that are hiring you, and they have to understand what's important to you. And you have to find this meeting of the minds. And I was successful at doing that, but I knew that for it to continue, it had to expand beyond the Department of Medicine for it to be expansive like it needs to be. Next slide. So this is interesting. We have something we call a mastermind series that we do about twice a month. It's a Zoom meeting. Somebody presents either a project or a topic. And everybody that is a member or an associate member is invited to attend. And so you see a screen full of people, including me and including Louise and Alan, but also you have people that are in the administration, in quality department, for instance. The chair of the medical advisory committee is sitting there. We have people from other departments who actually were doing projects, and some people that from the Department of Medicine that I was mentoring as well. In the close to the middle of that screenshot, we have the corporate medical executive, which is like a medical VP, and we had the chair of the medical advisory committee who oversees quality. So we had those people really in the center of things in order to support us, so they could see what we were doing and how we were doing it. The Mastermind series is very successful. There are things to learn. People, if you do a QI Masters, you're learning, the essence of lean, maybe theory of constraints, Six Sigma. It's a little bit of statistics involved, but you don't necessarily think like a researcher does. And being able to bring in people with research backgrounds and actually talk about how they design experiments or how they think about it, I think that was also important for the faculty of Sequence to actually hear about, so they could be maybe a little bit more daring in what they were trying to do. And it's resulted really in a number of papers that we've written. I've done one looking at the use of a smartphone versus a coach in heart failure. We did a paper on creation of a remote virtual clinic for COVID patients, which took a lot of strain off of our beds. And so we have looked for these opportunities to turn our projects into publications. And to me, that's where I wanted to end up anyway, but it was kind of a long road getting there. Okay, next slide. Again, I think this is really just showing the result, the courses, the numerous QI projects that have been initiated. You can see that we have done a lot of projects. We do about 7 projects a year with Ivy students. We do a similar number with people that have enrolled in our certificate program, in addition to independent projects that people may have done that are physician-led and physician investigator driven. Next slide. And this just shows that all of these projects were not just done in the Department of Medicine, that they were done in other departments. And that's when you know that you got a good idea. Okay. If it's spreadable that quickly, then it's something that is needed, and people are going to turn to you because you have something that you can offer them. Next slide. This is just the results of the Ivy collaboration in 1 year. This was interesting because the Ivy students were matched to an attending in the hospital or an administrator even to do a project that people thought needed to be done. And so, for instance, in thoracic surgery, we have reduced length of stay in pleural effusion. That's not a project that I would necessarily do. On the other hand, Rod Bagger led a project on early discharge following ST segment elevation MI, which is a project that I probably would do myself. But then you can see that there's a lot of diversity here in terms of the subject matter, which to me is cool.
Yeah. Yeah. The broad range of projects.
Next.
Definitely.
Yeah. Yeah. Next slide. And these were just to show the divisions of medicine that were actually affected. And we had pretty good penetration in all of our divisions. So I was pleased with that. You can't command it to happen. What you really are trying to do is to build a garden where it can happen, that there is the support there. But the ideas have to come from people, and really the blood, sweat, and tears also has to come from people to actually do the projects. But people want to do it. It's part of, I think, being a physician is that you don't want to be always relying on the status quo because you know deep in your heart that things could be better.
One of the questions that Don just put in, which I kind of think maybe you could further elaborate on this, but how did you get the other departments to adopt the approach? How did they become aware that you had started this sequence structure within the organization?
A word of mouth would probably be I think was the most effective. Now, yes, I did presentations. I did a presentation early on for the chairs. And I was actually the chair of the committee of chairs, so I had some influence on the agenda. I got it on the agenda. But what I think really happened is young faculty coming on are trying to find out what is it they're going to do to be an academic. And some people like to teach, but some people look around and say, we could be doing this better. We could be doing that better. And then they start to get themselves educated in QI. And then they realize, where do you go in the hospital or in the university for support? And that turned a lot of people towards us. And the chairs of a respective division might actually come up to me, or a department for that matter, and say, I have so-and-so who's quite interested in quality. What else can I do to help? So we had those kinds of conversations, and then I actually put together a pitch.
Okay.
To department chairs to actually support. And the hospital, I spent a lot of time actually talking in hospital leadership about the value of the program. And eventually they could see it themselves because enough of them were attending mastermind series or were involved in projects that, and we actually had them as judges on these competitions. When we do a competition, whether it's the hospital or the Ivy, we do a competition and we bring people from the administration, like presidents and deans, to actually sit as judges on the project so they can see it for themselves.
Great.
Next slide. I just wanted to just show some of the work. Anesthesia, we had one person that was interested in quality in anesthesia. I'm not really sure what their project was because I wasn't involved with it, but they put together a nice dashboard. And again, I think that what I came to realize is that data storytelling and dashboards are actually very important in business, probably more so than what I got out of Pemba. And I actually took a course on it myself from the University of Chicago on data storytelling. But here, one of the anesthesia attendings was actually starting to put together the baseline of some of the KPIs in anesthesia, looking for opportunities to improve. And so that's a pretty basic kind of project to get started, to actually just see what the state of things are. It's kind of like in the plan part, right, of a PDSA cycle.
Yeah.
Next slide. This is a discharge summary. I would say discharge summaries became a bane of my existence. You laugh, so I assume that touched a nerve. But and in the we have a regulatory college in Ontario, the Ontario College of Physicians and Surgeons of Ontario. And they created a mandate that discharge summaries had to be completed within 48 hours of discharge. This was not being consistently done. I'm not even sure I could say it was always being done. No, you can see the variation here. But one of my colleagues in the department was kind of interested in this as a project. And actually, and we had another department which was quite interested in improving their below average performance. And this is just the results of where we were able to actually take the hours from discharge to the sign off by an attending. Interestingly, the problem was not the residents, was not the transcribers. It was essentially the attending signing off at the end. Part of that was because some attendings are very particular about the words and the specifics. And so they would want to have revisions, and which caused delays and would kind of put you over the 48-hour mark. But nonetheless, we did that project. That was a corporate project where we needed the assistance of other departments as well as the hospital to actually do it. But it was one of those projects that's kind of consistent with the mandate and the mission of the hospital, and that they should be supportive of. And so we went about and did it, and there's some results.
Neat.
So, I mean, I'm sure this drives everybody crazy. I would say that IT has not helped us. If I had a retreat before I left and broke it up into 6 different topics. One of the topics was physician wellness and causes of burnout. IT, electronic record, kind of led the list. So doing the discharge summaries in 48 hours was not a happy experience.
Yeah.
I just wanted to show that on the career development side, that we had people that are doing quite well and that are becoming leaders in their own right. Allie Bateman and Aaron Spicer are two, but they're not the only ones. But certainly there were two that were notarized by having won an award on their work. And you realize that these people are, at the time that they won the award, I think that one was out maybe a couple of years and one was out about 4 years from when they started. And so the leadership is showing up very early on. And we wanted to make that known. But I think it's another sign of success of the program that you can actually develop leadership in this over time. It's a longer term, but this is an early return. Next slide. So we thought that there are a lot of impacts of sequence. Certainly, I think we are expanding the necessary infrastructure to do it well. And doing it well means that you have to actually have data, and you also have to have ideas, and you have to have leadership that actually has followers in order to get anything done. I think sequence actually facilitated a lot of that. We developed and created delivery of educational opportunities for staff in addition to physicians. I think that having sequences was a recruitment tool and a retention tool for physician staff. I think the whole idea is around making things better for patients in a sustainable, systematic way. I think that my career has really been mostly about doing that, but I think the idea of spreading my ideas beyond required something like a center in order to have that influence.
Well, I think your recognition that it's a recruiting and retention tool, I do think speaks to what you talked about earlier, and that is the vast majority of physicians want to participate in improvement efforts. They want to continually do a better and better job for their patients. I mean, that's kind of in the DNA of being a physician, I think.
I think it does too. You don't need, people want to do it. You just, instead of having, a stick or telling them no, you have to kind of help them get to a point where they can make progress. and see that. I think it's really important. I think the idea of collaboration was important, and I think we've demonstrated that. I think in the future, if I were still there, I'd be pushing more for actual patient improvements in patient care as it relates to evidence-based medicine, timeliness. And I think that for the future of sequence, having an awareness and profile of surrounding hospitals is important because they don't have the expertise in the smaller hospitals. They don't have enough staff or resources to do it. And so being able to act as a consultant or an educator could be very beneficial to the public that we serve in a broader sense. Next slide. I think we're getting close to the end. Next slide. Okay. So, after you kind of run around in the woods for a couple of years, you sort of say, I'm expecting that at the 5-year mark that we built a strategic plan would be in good shape. It turns out I started building the strategic plan around partway through the second year. I had a facilitator who had helped me with strategic planning in the department, who we were always on the same wavelength about what this should look like. And so this is an outline of what we came up with, which I think encompasses much of what I've talked about. And this is I had to break this down into separate slides to actually demonstrate to the department chairs just exactly what sequence could mean to them and why it's a good thing. But this was really a comprehensive approach of what sequence could become in the future. Next slide are the membership benefits. This is something that's got to work for the people, to be honest with you. So we bought QI macros, or at least we ended up paying a discounted price. We created stats and data analytical support within the department that actually served projects. Mentorship and coaching, talked about the Mastermind series. The coordinators that we've hired are actually do projects for departments besides the Department of Medicine, and they get paid for their time. Educational events, I've alluded to that. Community of scholars, I think people want to be a part of it. We've sold merchandise. I think that it's actually, as I demonstrated with Allie and Aaron, is that it's an opportunity for people to step forward and take on a leadership role, knowing that what's behind them is support. And so I think that has been one of the reasons that we've also attracted people. Next slide. So I think in a very short time frame, that in business school, you're trying to make a profit like yesterday. Certainly within 2 to 3 years. This is not a project that's about making money. At best, it helps reduce cost, I would say. Doing enough educational activities to pay for ourselves is still a challenge. But I think that we've established the concept fairly well, and that we have been serving the faculty as well as the hospitals. Any faculty member hired into the Department of Medicine or other departments is not an island unto themselves. They have support. They have other people that they can connect with to talk about projects or talk about things that they might not know about. Here I was talking about theory of constraints, and everybody's eyes kind of glaze over, much like business school. You start talking about that, but that's the kind of stuff they need to hear that they might not have gotten in the quality master's degree. So you have to spread it. And I think that there is a continuing need to learn new things. For instance, I talked about something like data storytelling. I never heard of data storytelling, although I had done it all of my career. Because as a researcher, that's what we do. We create stories around data. But the fact that the graphics are better, that you can actually get large data sets with lots and lots of variables that you can look at, really means that you can explore things in a much more comprehensive manner and present them in an understandable way. I think, faculty needs continuing help with that. We did statistics, one on analysis of variance, and you'd think that they know this, but they don't. Or they're not comfortable with it, certainly. But that we did we were able to do those sorts of things, and I think that makes people all better. And we completed some projects that were important to the missions of the institutions, and other people saw its value who were not really part of it. And so I think that it was an important thing to do to have impact. I think one of the things as a leader, you got to figure, okay, well, what does the leader do? And one of the things you have to do is kind of figure out what the destination's supposed to be and what the direction's going to be. And I think that sequence was I think a very important tool to have more influence over more people in a short period of time. And in Canada, a chair serves for 5 years and he's renewed for a 5-year term. 10 years is not a long time to get a lot done, especially when it's in a mess to begin with. So I think sequence was kind of a valuable means being able to achieve an end of change. So I think that's it for this one.
Great. Thank you for sharing that project with us. I think that was really great. If you don't mind, I'd like to kind of ask you some questions about your decision to pursue the MBA and the impact that that's had on your career, if we have a few more minutes.
Well, it's interesting. You know, I have a rather eclectic career, to say the least. I've trained in internal medicine, critical care medicine, cardiology, invasive cardiology, and I did 2 years of research at CVRI. So I've done a lot of different things. And as I think what happened in my career was that because I did a lot of things, it kind of positioned me to be influential, which kind of led to higher and higher levels of leadership. But once you're at the level of senior leadership in the hospital or of a major division or department, things get more complicated. And to be honest with you, when I took the chairmanship of rush cardiology, I actually did an executive leadership course, which is kind of like 10 weeks, 3 hours a week, which kind of got me through 10 years. But in the 10 years, the competition in Chicago was immense. I was on a lot of pressure to try to increase market share. And yet I think structurally we didn't have all the pieces in place, but somebody had to take the heat for it. I took a lot of heat. And I actually ended up having to reduce the faculty number from 43 down to 13. And I wrote it up in a paper, Overcoming the Perfect Storm, because that's kind of what I saw, all the forces that were at play. It was that would basically drown you. And I knew then that if I was going to go any further, I needed to have better guidance than what existed within the hospital. Their ideas were not necessarily the same ones that I would have had. My confidence was very shaken by that experience. But so I said to myself, I got to find out. I got to find out what true is. And because laying off a lot of people in the end creates problems of its own. So why do you make me do stuff like this? Just to kind of balance the budget in a year? So I thought that there was a need, and I liked it, actually. I mean, I got kind of used to doing it after a while, but I wanted to know I was doing it right. And so I looked around for MBA programs. Pemba, what was inviting about Pemba was that it was a year. I could still work. I could manage the cost of it. I thought the online experience was something new that I hadn't done before. That would be interesting. But I also thought that the in-person sessions are great too. There's some things that you just need to do in person, I think, especially with group efforts. And so you got to meet people, people from all different walks of medicine, as it were. And that was very enjoyable. I would, there are a lot of things that transform your life and your career as you go by. Going to CVRI was one of those transformational experiences. Walking through hell, which is what I was doing in cardiology, was one of those transformational experiences. Pemba was one of those transformational experiences. I was not the same after it. There were just things that I could see I could do that I couldn't see before.
What was one of the things that you took away from the MBA program at the University of Tennessee that you didn't really anticipate getting from the program?
Well, I think there's a lot of things. First of all, it built up my confidence. That was good. I think you need to have confidence when you're going into the boardroom. You have to be able to speak to truth, speak to power, and you got to, you have to have the confidence that you're saying the right thing and how to make the argument. That's really important. And obviously, they actually worked on presentation skills and writing, which I had taken writing courses before, but medical shorthand is not a good way to become a good writer. So there are a lot of bad habits I had to actually improve. I think one of the things that came out for me was having a big picture about it all. Yeah, finance was tough, but I learned a lot about finance. But the idea of understanding what the pieces had to be, how they had to come together. So to give an example, I created a management control system, which I actually published. And it starts with a strategic plan. And I got a competent person to help me create that. But then I was able to create a balanced scorecard out of that. And I figured out how I could get the data for the balanced scorecard from all the electronic sources that exist. Then I created essentially feedback expectations for division chairs with their faculty. And then I would basically review the division chairs every year. So we'd have a sit down, and so we created accountability along with feedback. And that had an influence on people because they knew somebody was watching. And how you reward people is important. How you reward people tells people an awful lot about what it is they have to do. And I think by having the balanced scorecard, we were able to be effective in projecting what our aspirations people. I'd go in and have to explain why we're doing a balanced scorecard. And I said, I owe it to you as the chair of the department to tell you how you're progressing. This is how I do it.
Great.
And
well, we're running out to the end of our time here, and there's a lot more things that I think we could talk about, but I appreciate you sharing your project with us in developing Sequins. And I'd love to potentially explore the possibility of having you back on another show where we could talk about some of the ways that you took the lessons from the MBA. I know because of our conversations leading up to this live stream that you've done presentations on that in the past. So I think maybe we'll try to bring you back on the show in the future and see if we can have a kind of a deeper dive into some of those lessons that you learned and what you took away and how you implemented those in your career.
Love to do it.
So that would be great. All right. Well, thanks again, Jim. And thank you to the audience for joining us today. Appreciate everybody taking the time out of their schedule to join us. And we, just as a reminder, we do have monthly live streams that discuss different topics. Our next live stream will be in November on the third Tuesday of the month at 12 noon again. So please join us then for another Pemba On Demand live stream. Special thank you to Kate Atchley, Executive Director, Healthcare Division, Graduate and Executive Education at Haslam College of Business, and Dr. Don Leiter, Professor at the University of Tennessee and Director of the Institute for Healthcare Quality, Research, and Education, for both of their support for this program. Thanks also to Tom Brown and Christy Napper for their support. I couldn't really do this live stream if I didn't have support from all four of them. Another reminder is that we release bi-monthly podcasts every other Thursday, including repackaging our live streams as a podcast. So we will be releasing a podcast this Thursday on the 17th. And information on the podcast and how you can subscribe and access the podcast is available on most of your favorite podcast players. We're available on Apple Podcasts, Castos, Overcast, Pandora, Spotify, and you can also go to YouTube, www.youtube.com/@Pemba On Demand. It's all one word with a hyphen between on and demand, and you can search there. Also, don't forget that CME is available for the live stream at tiny.utk.edu/Pemba On Demand, all one word. So please log into that website and sign up for your CME certificate. Thanks again for joining us. I hope you all have a great month, and I look forward to seeing you back at our November live stream. I hope you enjoyed this episode of Pemba On Demand, taken from our October 15th, 2024 live stream with Dr. James Calvin. Dr. Calvin did a great job of highlighting the value of a Center for Quality, Safety, and Innovation for any healthcare organization. Remember that Pemba On Demand podcasts are released bi-monthly on Thursdays. Please join us in 2 weeks on November 28th, 2024. We look forward to you listening to our future podcasts. That wraps up our show for today. Thank you very much for joining and listening to the podcast. If you have any comments or questions regarding this episode, please feel free to add them in the comment section on our website, tiny.utk.edu/POD podcast. We love hearing from you and are happy to answer any questions you may have. I will add a link to the website below. Please also don't forget to subscribe to the podcast by clicking the subscribe button. Add Pemba On Demand to your podcast library today. I would also appreciate it if you could leave a review of the podcast on your podcast player. Share the podcast with your friends and colleagues also. Please take good care of yourselves, and as always, good luck with your future.